I was thinking, I'm not sure why it is that I like to do this talk. I think it's 20% of people in an outpatient psychiatry service have this diagnosis. So really it's a very common diagnosis to be seen in a psychiatry service. On an inpatient adult unit, 10% of people have this diagnosis. So we see a lot of it. It's different for me to talk about because it's not an illness. It's not schizophrenia or bipolar disorder. It's a kind of personality adaptation that causes people problems. And it causes lots of interesting problems, I think. And I guess the other part of it that's kind of fun for me, I think, is, it's been a very poorly understood thing for a very long period of time, and it's been a very poorly treated thing probably for a very long period of time. And now I think we understand a lot more about what this disorder is and what we can do to help it. So I think it's just sort of relatively new in the world of psychiatry that we've actually got it pinned down and can diagnose it better and can treat it better. So it's kind of, it feels like a fun thing in lots of ways to treat and to talk about. So let me just carry on with that. So as Vicki said, I'm going to talk. I should be able to do this in about an hour, and then if anybody has questions, we can certainly talk about them. And if for some reason somebody wants to talk to me after the presentation, I'll hang around for a little bit if people have any more private questions or don't feel like sticking their hand up in the air. So let's just work our way through this. I'm going to talk a little bit, mostly I'm going to talk about how do we make this diagnosis and then go through the various criteria and explain them in a little more detail. And I'll talk a little bit about treatment, I think, and some of the problems that these people get into. And then just at the end, I'm going to do a few 10 minutes maybe on different sorts of personality disorders just to round it off. This is the one, as I've said, that we see commonly showing up in psychiatric services, so we're going to focus on that. So, for a long time, the word borderline has been around, and I think for a long time we've been using it in all sorts of different ways. When I was young, we used to talk about people that had borderline schizophrenia, meaning they seemed like they almost had schizophrenia or not quite, or people that had borderline neurosis, which sort of meant back then that they had some almost a neurotic condition, but not quite. So it's been used for a lot of different things. And you can see on here that originally it described a constellation of symptoms that was sort of considered to be in the borderline or between this whole concept of psychosis, where people are out of touch with reality, and neurosis, where people have emotional conditions but are completely in touch with reality. And then when it became introduced in our diagnostic manual, the 3rd edition, so I think you probably all know we have this thing called the Diagnostic and Statistical Manual that psychiatrists in North America use to diagnose conditions. And every once in a while we go through a revision. So in the last year we've come up with DSM-5. But in 1980, the 3rd edition of the DSM came out, and borderline personality disorder was included then. Prior to that, it had been used to mean a bunch of different things, including these, sort of illnesses on a spectrum, particularly difficult patients. It was referred sometimes to people with conditions that we couldn't quite understand and we weren't sure what they really had. It's been used often to describe a personality. And for a long time, I think when I was probably 35-ish working in Edmonton, we talked about it as being a type of schizophrenia. It was sort of a borderline schizophrenia, kind of a mild schizophrenia, right? And so it's often been used to refer to symptoms that border on the edge of an illness. So even outside of psychiatry, we could talk about people that have borderline diabetes, borderline heart failure, borderline, all sorts of stuff, sort of meaning not quite. So in the past, it has often been considered a variation on schizophrenia or a variant of bipolar illness. Now we know, and the research supports the notion that this is neither of those. It is, in fact, an independent entity on its own, and it's not a subtype of either schizophrenia or bipolar disorder. So this slide, I think, kind of highlights the things that I think, as we go through this talk, I'll show you some slides with all sorts of little points about symptoms that people can have with borderline personality disorder. And when we're all done, you may be more confused than when we started, because you can't be expected to remember every little thing that we're going to talk about. And it's really important to It's really important to remember that when I show you a slide that has 8 possible symptoms for borderline personality disorder, that you don't get it in your head that everybody with this disorder has all 8 of those symptoms. Because we're going to be talking about possible groupings of symptoms. But I think this slide, in my mind, kind of gives you an idea of what to expect when a borderline patient wanders into your office or into your hospital. So chaotic relationships are, kind of classical. The borderline people typically are thought of, when I think of borderline people, one of the things that comes to my head is just this whole business of chaos. So whether you're talking about relationships, they have endless relationships. And they're chaotic relationships not just because they have a whole bunch of different relationships, but often, they're chaotic in the sense that, they can be very short and very intense and very rapid and end up in disaster and people jumping from relationship to relationship. And you see the same pattern in other areas of functioning. So you sort of see this chaotic work history, employment history, friendship history. There's chaos all over the place. People are chaotic in their choice of drugs and the kinds of drugs they use, and it's just chaos. So relationships are a pattern of markedly unstable, intense relationships, and really moody people. So when we say that, the borderline people are thought of as classically people who could be, very anxious and upset in the morning for some reason. Maybe in the afternoon they're on top of the world because they had a really nice phone call from their boyfriend or their girlfriend. In the evening they're mad as can be because their mother's upset with them. So you see this enormous fluctuation, volatility, and sort of chaotic mood picture. So I think if you kind of keep that in your head, these chaotic moods, chaotic relationships, chaotic work history, kind of gives you a sense when you see these people that are just all over the place in their relationships, in their work things, in their drug things, and again, not everybody has that, but I think chaos characterizes them pretty well. The other thing underneath all of this is these people don't really know who they are, and you'll see as we go through this talk that ends up with all sorts of different problems. If you don't know who you are, you'll maybe line yourself up with a bad crowd more likely than you would if you really had a strong sense of who you were, or you'll end up with somebody who's kind of an inappropriate partner for you because you don't really know how you fit. So not having a strong sense of yourself is, it's a pretty fundamental problem with the borderline. So often when I see borderline people and I'm trying to write some sort of a consult to the family physician and understand their sense of do they really know who they are, I would simply ask them if would they mind or could they, if I asked them to write me a couple pages on who they were. Most of them would not have any hope in hell of being able to write me more than a few lines, whereas most of us could easily, write a page or two about this is what I do, this is what I like, these are the kind of people I hang out with, this is what I do in my free time. The borderline people, more often than not, have a very poorly defined sense of who they are. So those are, in my mind, sort of the 3 probably most important things that we see. And some of them, they sort of feed into a lot of the symptoms and symptomatic pictures that we're going to talk about tonight. So we talk about very unstable people. So they are predictably unstable, or stably unstable, or predictably unpredictable, which is sort of appropriate little catchphrases, I think. So I mentioned that in North America we use something called the Diagnostic and Statistical Manual of Disorders. And that's how we make diagnoses in psychiatry, not for the purpose of making everybody with a psychiatric problem sound like they have an illness. The purpose here is for communicating. So if I phone somebody in Paris or Florida and say that I have a paranoid schizophrenic patient, they know what I'm talking about because we're following the same diagnostic criteria to make the diagnosis. So it isn't about medicalizing people who smoke too much tobacco or medicalizing things that shouldn't be medicalized. It's about allowing us to communicate more appropriately. So where I was trying to get to with this slide was to tell you that in Europe, they have their own diagnostic manual called the International Classification of Diseases, which isn't just for psychiatry, it's for all diseases. And in the ICD 10th edition, which is currently on the market, they don't call it borderline personality disorder, they call it an emotionally unstable personality disorder, which I think gives a more clear picture of what we're talking about than borderline. Borderline is just kind of a funny word because it doesn't tell you much. So this is a definition of the borderline personality disorder according to the DSM 5th edition. So this is my mistake and I didn't fix that. But they're pretty much the same, except they use a different name. So in our latest diagnostic manual, these are the criteria that a person has to meet for us to diagnose borderline personality disorder. So I'll just run through these fairly quickly, and then we'll kind of go through each one slide by slide and explain a little bit what each one refers to and explain it a bit. So according to the DSM-4, and now we're on to the 5th edition, so I should have corrected that slide as well. In the DSM-5, the diagnostic criteria are these. So you have to have a pattern that's pervasive of instability of interpersonal relationships, self-image, mood, and marked impulsiveness beginning in early adulthood in keeping with personality development and showing up in a variety of different ways as demonstrated by 5 of the following. So in order to make this diagnosis, when I see somebody and I'm trying to decide if this is the right diagnosis, I have to be able to say that they meet 5, I can check them off on 5 out of 9 points. And I think honestly that most of the people that I see that come into the emergency room that are having big problems with borderline kind of stuff, most people probably easily make the 5, and we see a lot of people with 8 or 9. So I think that sort of tells you that we're pretty good now at defining this personality disorder, because when we see people that fit into this category, they really do meet most of these criteria. We also see lots of people that meet a few, so we see people with normal personality development that have intensely unstable moods, or normal personality development, or other problems where they might be self-destructive but don't meet the full criteria. So you have to be kind of careful, because one of the things that's happened over the years, I think, is people, if you work in a hospital or if you know a bit about mental health, people think about borderline people as people who are very self-destructive. They think of borderline people as people who cut themselves, people who burn themselves, people who put their fists through the walls and are wildly reckless, and it's just not always true. So it's quite possible to have a borderline personality disorder without having those things that I just mentioned, because you could have 5 others. So these are them. They have huge problems with abandonment, and lots of us do. But I think in this, you can see here that under this criteria, in order to make this #1 point, people have to engage in frantic efforts to avoid abandonment, whether it's real or imagined. So just sort of quickly, if you see a young lady who's in a relationship and her boyfriend decides he's had enough of her and says to her, I think I think our relationship is over, then she not only gets very distressed and very hurt by that, but she will become frantic in trying to keep him. So that's kind of, you're doing this rage paging thing, you're texting and texting and texting, please stay with me, begging and pleading, and doing all sorts of frantic things to avoid abandonment. So then we've mentioned that the borderline people typically have very unstable and very intense interpersonal relationships. And in there we sort of see this business of people moving from idealizing the person they're with to devaluing them. So a kind of a synopsis of what a classical short-lived borderline relationship might be, with somebody coming onto our ward with a borderline personality disorder, might meet somebody, a young man, in the television area, and the same night they're talking about really meaningful, deep things, and they're madly in love with each other, and 2 days later it's all over, and then they hate each other, and so it's going from, this is the greatest guy I've met forever, to this is a guy I hope I never see again. And it happens in the world of therapy also, and it's a problem that all people that do therapy have to be pretty careful of, because if you meet somebody who attaches to you very quickly and they tell you all this very meaningful stuff in their life, and then they feel like you've really listened to them and you've heard them and you're going to take good care of them because you spent 90 minutes listening to all of that, and then they often will maneuver you into coming back and seeing you fairly frequently because they're pretty sure you're the fellow who's going to fix them. But then in a little while you realize that this is borderline, it's not bipolar, they're not depressed, and I don't need to see them too often. So then when you say, we're just going to see you once a month, then all of a sudden you have a little argument, and then they don't like you, and then they're complaining about you, and then they're hating you, or you're the worst guy in the world. So you can really go from being the most amazing doctor I've ever met, to I wouldn't send my dog to see you, and pretty quickly, So you have to be and that's not productive for anybody. So you kind of have to be careful in how you set your boundaries in dealing with some of these people. But as I said earlier, as I go through these things, remember that not all of these things apply to everybody with this diagnosis. And a lot of the things that may apply, of course, are seen in different degrees of severity. So, this valuing somebody and devaluing somebody in the way I just described, it doesn't happen horribly often to that degree, but it does. So, identity disturbance, this is back to what we talked about on the previous slide, a very unstable self-image or sense of self. Lots of impulsiveness, so usually we see that in areas of spending too much money, and this is really spending not too much money. We all spend a bit too much sometimes, or most of us. Spending tons of money and then having that end up causing you problems. Being very self-destructive sexually, so usually a lot of promiscuity or sexual things that people shouldn't get involved in that people deeply regret a little later. Lots of substance abuse is common, being very reckless when you're driving. Out of control eating is pretty common, and some other things that aren't mentioned here. Chronic suicidality is a pretty common thing that we see in the borderline patient. And it complicates things a lot. So when you're talking about chronic suicidality, we're talking about people who've kind of had thoughts of suicide in their mind for a very long time. It doesn't mean that they're suicidal at all every day. It means that, they frequently wonder if they should. They frequently wonder if their life is worth it. They just sort of play around with that idea a whole lot. So if you just could, ask a borderline person, how many days of the last 100 did the thought of suicide cross your mind? It would be an awful lot more than how often it crosses my mind. But it doesn't mean that they're on the edge of killing themselves at all. It just means that they think a lot about that stuff. So it's a lot different than predicting suicide risk. So they have that, the chronic suicidality. Often we see in the emergency room, they'll come in and have claimed to have overdosed on 500 Tylenol or something, and then we do a blood level and can calculate they probably took 2. So they do suicidal gestures, and they also do very serious suicide attempts. So I wouldn't want you to think I'm suggesting that they don't ever get serious about this stuff, but we see a lot more gestures than we see serious things. And then the self-mutilating things are these are the people that typically cut themselves. These are the people that typically burn themselves or hurt themselves in one way or another. There's a wide variety of ways that people can hurt themselves, and we'll talk about that in a little while. These are very moody people. I mentioned that earlier, going from being very anxious to being very angry to being very euphoric 3 times over the course of a day. Chronic feelings of emptiness. It always seemed kind of a weird criteria for me, but I find that I think honestly that 90% of times I meet somebody with a borderline structure and I ask them, do you think you feel empty? I expect them to say to me, well, what do you mean? I don't get what you're saying. But they almost always say, I really do. Like, it seems like they really do identify that. So it seems to be a pretty appropriate thing, a sense of emptiness. They have rage problems. They can get very angry, and they have difficulty controlling their anger. So that can be anything from being intensely sarcastic and being quietly seething, to throwing things around the room, to getting into bar fights from one extreme to the other. But they have problems managing their anger. And then sometimes they have short-lived episodes of paranoia where they really do feel that others are out to get them. And they have usually short-lived episodes of significant dissociation where they have periods, usually when they're under enormous stress, where they don't remember what happened. So a rage thing would be pretty typical if a young girl and a young guy were having a relationship and the fellow decided that he'd had enough and he was going to leave. It wouldn't be, one of the things that might happen would be the girl somewhere in all this terrible emotional chaos would become incredibly angry. And so angry that, who knows, scream and yell and throw things. And then the next day not really remember what happened during the time when she was so angry. And we see that in a lot of rage episodes. People are out of control so far that they don't recall what they did. And you see that in jail. So you see, it's kind of a sad story when somebody is accused of murder and found guilty of murder, and he honestly doesn't really remember the 5 minutes in which he did that. It doesn't absolve him of guilt, but you see more of that than what you would think. Rage is, when people are really raging, their brain is misfiring so badly that surprisingly often they don't remember. So now we're just going to go through these criteria and explain them a little bit, and I think that'll help you understand. So I guess just before I did that, I was going to just, for those of you who've been around for a while, you may have seen this movie. Fatal Attraction. So it was a movie that came out, I think, around 1980 or something, maybe 85. It's a really good movie. It had Glenn Close and Michael Douglas in it. And after this movie aired, people came up with this phrase, came out of this movie, the fatal attraction situation, which we use these days to refer to a situation where a lover who is spurned turns around and seeks revenge. So kind of in this movie, which, if you guys like movies, it's a really good movie. And if you really want to know what a borderline lady looks like, this lady did an excellent job. It's probably the best portrayal of a borderline person I've seen in a movie. And you see a lot of this fatal attraction theme is commonly used in movies, but this particular movie, although it's older, really did it really well. So Glenn Close was this woman, Alex Forrest, who was an editor, I think, and she met up with Michael Douglas, who was a lawyer, and they ended up getting together for the night, and the next day, I think she thought that things would carry on, and he'd already made it sort of plain to her that he was married, and he was just going to be with her for one night, and so he rejected her. And then she, pleaded with him not to go, and she did everything she could think of to talk him into staying. But then she became very angry, and then I think she murdered his bunny rabbit, and she kidnapped his daughter, and it became kind of a scary, psycho kind of thriller. It's a really good movie. Anyhow, and then it was interesting, I think, that later when people reviewed the movie, they described this woman as being psychotic, antisocial, psychopathic, delusional, obsessed, all this stuff. So it kind of gives you a picture of, during the course of the movie, she goes from being this woman that people can identify with and say, isn't she just such a nice lady? Then she's kidnapping his kid, and then she's frantic, and it's just the shifting and the chaos you just see in this woman's personality over the course of the 90 minutes is interesting. So we're going to go through those 9 points one by one. So again, the essential feature of BPD is a pervasive pattern of instability of relationships, instability of self-image, instability of mood, and marked impulsiveness. If you don't know, this affect is something, if I want to know what somebody's mood is, I just ask them. And they say, well, I'm sad, so I'd write down her mood is sad. But if I want to record what their affect is, what's what they look like to me. So affect is a word that to a psychiatrist means this person seems to be displaying a certain type of mood. So if I look at you and think you're really angry, then I would say your affect is angry, but if you tell me you're calm, then I have to write your mood down as calm. So affect is just a descriptor to describe what we think somebody's moods look like. So the primary point, or the number one point, engaging in frantic efforts to avoid real or imagined abandonment. So when they perceive impending separation or rejection, or the loss of structure, this can lead in big changes to how they see themselves, because they often view rejection as meaning that they're a bad person, an unworthy person, an undesirable person. So they get this transient change in self-image. Then they could become suicidal, they could become homicidal, they could become all sorts of different things. So you get a different big change in the mood and the affect, changes in thinking and changes in behavior under those circumstances. So they experience truly intense abandonment fears and inappropriate anger, even if you give them a realistic timeline. So sometimes people who've lived with somebody with this condition for a while realize that they can't just get up someday and say I'm leaving, because all hell breaks loose. So they will try and say, we have to work on this for a month, and in a month it's going to be over, and we're going to try and go through this carefully, and we just need to keep it calm. And even with reasonable timelines and giving lots of time, the intense fear of the abandonment still is something that these people can't handle, generally speaking. And as I've said, sometimes abandonment to them would imply that they're bad or not good enough. And part of the abandonment issues is that people don't do very well alone, so if you fear rejection, a lot of different things happen. If you fear rejection, then when people are always rejecting you, end up having these overwhelming, horrible days when people leave you. And sometimes what we see is people, I'll see somebody who's perhaps 30 and say, well, do you have big abandonment issues these days? How wild and chaotic are your relationships? And they'll say, well, I don't really do relationships. But then if I say to them, what about 10 years ago? Oh, well, then I had tons of relationships, And I had all these breakups and they all broke my heart, and I had all these problems with abandonment, so now I don't do relationships. So sometimes you see people who are no longer doing relationships because they figured out that it hurts so much that they don't do them anymore, which gets pretty deceptive. You're seeing some girl or some fellow who's 35 years old who says he hasn't dated anybody for 6 months. You might quickly jump to the conclusion this is not borderline or some kind of character disorder where they have relationship problems. But people learn what hurts them very seriously and then sometimes avoid the problem. So we've said all of this, I think. So these people have a pattern of unstable and intense relationships. Said this also, they idealize potential caregivers or lovers, and they sort of move to discussing very meaningful, deep things that you and I wouldn't normally to discuss until we've known somebody for a year. So in the first or second meeting, they're telling them all this very private, personal stuff, trying to cement the relationship, I guess. Then they're very demanding of wanting to spend more and more time together. They can switch, as I've said before, from valuing somebody enormously to devaluing them very quickly, feeling that the other person doesn't care enough because they're not willing to spend as much time with them as what they were hoping. And it's also probably important to realize that borderline personality disorder people are quite capable of empathizing and nurturing other people, but they expect to get it back. And if they don't get it back, that's when the problem comes in. So, you know, really, in my view, borderline people are wonderful people. They're very emotional. They're the kind of people who want to be caregivers. They're the kind of people that want to reach out and rescue people. They're the kind of people who feel like they're tuned in to other people's emotions, but they have difficulty regulating all that stuff. So I find that, you know, they're a lot of fun to work with because, you know, they're very kind people. Often they put other people's needs ahead of theirs. They're always reaching out and rescuing people, but somehow all of this turns into chaos for them and their life doesn't go very well. But I think fundamentally they're emotional people, and they, you know, if you want to help somebody grow through therapy or watch them, help them turn into better people as they get older, they have that fundamental caring, which is pretty nice, because when you're dealing with certain personalities that don't have any ability to relate or connect to other people, you're kind of limited in what you can expect for the long-term future. So if you're starting with somebody who's highly emotional and you can teach them to regulate their emotions and use them appropriately and understand them appropriately, you know, I think you have some chance of helping them to become successfully functioning emotional individuals. So they do this, again, they have this sudden and dramatic shift in their view of other people. So the identity disturbance, you know, where I see this, I often think back to a couple of years ago, I had a young lady, a really interesting young girl who was probably 20 years old, I think, and I saw her from the time she was in grade 12 till she was probably 22. And I think when I met her, she was going out with a farmer. So she came into my office and she had big blue overalls on and she looked like a farm girl. And then a year later, she fell in love with some guy who was taking physics at the university. So she came in looking like a girl who should be attached to somebody who was taking physics at the university. And then later she was going on some big mission to save all the kids in India and came in with some tie-dyed floral dress down to her ankles. And so you can see this, her self-image was unstable. And, you know, when I ask people about that, when you date different people, do you find that you sort of morph and you move over and become sort of like them? And it's interesting when you describe that to people, they identify it with it really quickly, where they realize that, you know, they can fall in love with a wide variety of different sorts of people. And then if that relationship lasts for a while, they become more and more and more like the person they fell in love with. And so they do this chameleon sort of morph-like stuff where they become more and more like the person that they're with or with the group that they're wanting to be with. And if that all blows up, which it probably will eventually, then later then they go back to feeling empty and not knowing who they are. But if they find a new group to hang out with, a new boyfriend, they become different. And it's really kind of interesting to watch if you're lucky enough to know somebody like this long enough to see that sort of changing. And that's kind of how I sort of see this identity disturbance manifesting in my office often. Also, you know, not knowing who they are, not surprising, they have career changes. So these are the kind of people that will come in and say, oh good, well now I'm going to school and I'm going to be a pharmacy technician. And the next time you see them, they're going to go work with animals after they've been to Olds College, and then the next thing you know, they're going to, and the diversity of the different career choices they make you sit back in your seat and wonder, what the heck is this about? Because you don't expect that, right? So it's connected to not knowing who you are. And the sexual thing is the same. I had a girl, I mean, we see lots of this stuff, obviously, but one girl I remember well was, came out of a small town in central Alberta, grew up in a pretty rigid home, and when she was in high school, she dated a little bit, and I think she was, probably the smartest girl in her class in a small town. I think she was voted the most likely to succeed, dressed like a successful student, dated a couple of guys that looked like they were going to be successful students, and then went off to university, and then all of a sudden got into one faculty and changed after 6 months and went into a totally different faculty. But when she went to Edmonton, she fell in love with a fellow in Edmonton, and that went along pretty well. And then she was hanging out with this, somehow it went from her being in love with this fellow, and then a little later she thought maybe it'd be more appropriate for her to fall in love with his girlfriend. So then she switched from being heterosexual to being gay for a while, and then later they decided that maybe it'd work better if all three of them had some kind of a sexual relationship. And you can just sort of see this changing thing going on all in the course of less than 6 months, I think. And she was a really interesting girl, and quite a dramatic example of sort of the sexual difficulty trying to figure out who they are sexually. And I think that these people are part of the reason that, when in these highly specialized clinics where they screen people for having sex changes, this is the kind of stuff they watch for, because sometimes you'll see people who they really don't know who they are, and then they kind of wonder if maybe I don't seem to be doing all that successfully as a young man, maybe I should just try being a young girl. And so you see some of these people applying for sex change operation that don't fit the real criteria, and really the problem that's going on seems to be that they're just kind of lost, and they don't know who they are, and they're just sort of trying to find something different, but at an enormous expense. I mean, you can't be surgically reversed and expect to turn that backwards very easily. So we've said this before, sometimes when these people come into therapy or in to see a family doctor and to see somebody like myself, they become, really pleading with you for help. They feel very needy. They want a lot of your time, and they seem to be, demanding of your time. And then if they don't quite get what they think they need, they can turn out being very angry. And often we see with these people, it would not be uncommon for me to go into the emergency room and be called by the crisis team to say, I have this young borderline girl here. And so I would go down knowing that I'm going to see a borderline patient, and then asking them about their past psychiatric history and wanting to know who looked after you last and who looked after you before that and who is your therapist. And they'll run through this long litany. Well, I saw Frank in Grand Cache and he failed me, and then I saw Judy in Pinoca and she didn't work out for me, and then I saw somebody else and he was no good for me. So all of these people who probably at one point were wonderful, in their minds have now become completely devalued. So everybody let me down, nobody helped me, nobody was there for me. So it's often kind of a thing that makes you think a little bit about what sort of people can go through a dozen therapists and not find anybody that works for them. And I think if you go back in time, if you could go back through the old charts, you'd see that often these people attached pretty well and entered into therapy with a very positive attitude, but then it all fell apart when they didn't seem to get what they needed or things didn't work out well. So the impulsiveness usually shows up in these areas. They can gamble, they can spend way too much money irresponsibly. Eating disorders are fairly common, usually bulimia. Lots of substance abuse is common in the borderline people. Reckless stuff, sort of sexual recklessness in a variety of different ways, driving too quickly, and a lot of other very reckless things. So we talked about this ongoing suicidality. It can be it's a chronic suicidality picture where, either can be chronic in the usual sense of the word or else recurring or recurrent. So people can have, with borderline people that are kind of moderate in their symptomatology, often they find themselves in a relationship that might work fairly well for a year, and when things are going their way and their job is pretty good, and the fellow that they're living with is all working out pretty well, a lot of this stuff sort of settles down. So you get this pattern of, they seem to be okay when things are sort of suiting what they need, and then when it all falls apart, they'll go back into this sort of a lot of suicidality with suicidal thinking, suicidal gestures, threats, and self-mutilating behavior. So I noticed that every time I talk about borderlines, I'm talking about girls, and I shouldn't be. The incidence of borderline personality disorder in boys is about the same as it is in girls, but it's hard to prove that statistically. If you look at how many borderline diagnoses are running around in the psychiatric ward at the hospital or in the outpatient clinic, they're mostly women. And there's complicated reasons for that, but it's not that women are more commonly borderline, it's kind of equal. But the women either come for help more, get into more trouble with it, or show up in our offices more. So it's important to remember, I guess, that almost 10% of these people will successfully commit suicide. So that's a bit of a tricky thing, because I think if you spend time in emergency rooms or trying to train your staff to work in an emergency room, the thing that gets focused on is don't get too, you're telling your nursing students or whatever, don't get too caught up in all the people who are saying that they feel like killing themselves, because some of them, the borderline people, are more likely to be there, feeling like their life isn't worth it and wondering if they shouldn't kill themselves and making threats and gestures, but not really being actively suicidal. But you can be sure that they're feeling horrible, but often they're not really an active suicidal risk. So we're trying to train our staff in the emergency room to spot the people who truly are a suicide risk and get those people in the hospital, and spot those people who are talking a lot about suicide but aren't genuinely at risk. Because we don't want to admit people who are not at risk, partly because they don't need to be there in terms of keeping them safe, but also there's a lot of reason to think that admitting the chronically suicidal person who's not actually truly in danger, if you admit them to the hospital, sometimes things get worse. And we're going to talk about that in a little bit. So it's important for staff to kind of separate that, but it seems like a lot of times when we're talking about borderline personality disorders, the emphasis is on try to keep them out of hospital, try to keep them out of hospital, but you need to remember these people kill themselves 10% of the time. And you need to be able to identify the situations in which they're much more likely to be at serious risk, and not always look back on the chart. And because typically if somebody comes into the emergency room, then the crisis worker or myself will look back on the old chart, we'll see what the diagnosis is, and if I walk into the room thinking, this is a borderline girl and she's going to be talking about suicide, but I know she's not suicidal, I'm making a big mistake, because this person is much more likely to kill herself than somebody who doesn't have borderline personality disorder. So it's important to kind of get that. And I think for families also, because you hear this business of, they're always talking about suicide and they're cutting themselves, but that's not really suicidal. It's important not to start thinking that these people are never dangerous to themselves, because that's not true. And sometimes you just don't know. And families will say to me, how do I tell? Well, sometimes it's really hard to tell because it's tricky. And that's when you should take them to the emergency or should take them to somebody. You can't afford to say, I think she's just trying to get in the hospital again, and never take her seriously. Unless you know your child very well, or unless your caregiver is giving you some really careful guidelines, it's not always an easy thing to differentiate. So usually these people come into the emergency room because of the suicidal thinking. Their self-destructive acts get lots of attention, so we see a lot of people are cutters. Not lots of people that are cutters aren't borderline personality disorders at all, but I think this is the most common diagnosis where we see cutting. And it's important to know that for the most part, cutting, if you ask patients to explain to you why do they cut, they will tell you that in certain situations they feel overwhelmed with emotion and they can't handle their emotion and they feel like they're going to explode, and so they cut. And they discover that if they hurt themselves, if they smash their fist into the wall, or if they cut themselves, that suddenly all that wild emotion that they can't handle at all seems to calm down, and they sort of refocus from being overwhelmed with unimaginable emotional turmoil to noticing the pain in their arm. So it's kind of a, when you think about it, if at one of the worst moments in your life when you feel like you're going to explode emotionally, you hurt yourself, and it works, it's kind of hard to quit doing that, you know, because if you find something that works, it's kind of like, you know, if you discover that when you feel like you're in some sort of a murderous rage, you just have a little shot of scotch, you're likely to go back and have more scotch when it happens again. And when people start cutting and realizing that it's a very effective way to take them out of this intensely emotional, uncontrollable situation, then not too surprising they do it again. And you kind of have to be careful about how judgmental you are about all of that. I mean, because these people don't want to have arms that look like road maps. They don't want to be scarred all over the place. And you can be sure that 99% of people who are cutting themselves, they really don't want those scars. And they, you know, they don't want to be doing that, and they don't really need a whole bunch of people suggesting that they're bad for doing that without really understanding what's going on underneath it all. So sometimes when people self-mutilate, they just sort of get this dissociative moment where they feel like they can calm down. And then of course it becomes quasi-addicting and happens over and over again. So, you know, the classical, I guess the most classical picture then would be if you have a borderline girl who's in a relationship with some guy and he decides he's had enough of her for the night, or he's leaving and she doesn't want him to leave and she feels very rejected, is terrified that she's going to be left alone, feels that she's a terrible person because he doesn't seem to want her anymore, and she's overwhelmed because part of her wants to hate him, part of her wants to scream at him, part of her wants to do everything she can think of to keep him there, and she's in this horrible emotional turmoil, and then she's on the verge of raging and she cuts herself. So that would be the most common thing, and then she calms down, and that's kind of the thing that often, the scenario that we see with people coming into emergency. Very moody people. So with this disorder, it quite commonly gets misdiagnosed as bipolar disorder. So in both bipolar disorder and in borderline personality disorder, both of these groups of patients have moments or periods of time in their life where their moods can truly be described as euphoric. They totally feel on top of the world. They totally feel like nothing can go wrong. For the bipolar patient, it has to be at least 4 days, usually more. For the borderline patient, it's more commonly a couple of hours, sometimes an afternoon, rarely a day and a half. So that's a huge difference. So, you know, the intensity of the euphoria that the borderline patient feels when everything is going wonderful is euphoric, and it's a more than fair word to describe it, but it doesn't last long. And, you know, and that's where the mistake is made. And people diagnosing these things, if you go see somebody that doesn't work with borderlines very much, or perhaps a family doctor, or somebody that isn't keeping up on this stuff, as soon as they hear that you have periods of euphoria alternating with periods of abject depression where you feel hopeless and feel like killing yourself, their first thought is, oh, that sounds very bipolar. So we get a lot of people who get diagnosed as bipolar because they have these wild mood swings, and then I end up seeing them, or one of my colleagues ends up seeing them. And you know where I see most of it, it seems like, is in the rural communities. So we do a lot of telepsychiatry where I can interview somebody over a TV screen in Fox Creek or some very distant place where they don't have psychiatrists and they don't have a lot of mental health resources, and I'll meet some woman who says, "Morning, doctor, I'm bipolar. But I've been bipolar for 15 years, I've been on lithium, I've been on every drug ever used for bipolar, hasn't made a damn bit of difference. My life is still chaotic and I'm a horrible mess." And, you know, after a little while, you realize that the person never was bipolar, that she's been borderline, she's misdiagnosed, and so then you have a bunch of problems, including the fact that she's now on the wrong medication, she has the wrong diagnosis, and she's had 10 years where nobody helped her. So it's important that people realize that borderline people do become euphoric, but it's short-lived. But they become truly euphoric and exhibit very bad judgment in the setting of being euphoric, but usually not long enough to get them into trouble. You know, they don't have a week of it where they decide that they're going to fly to Vancouver and take over the world or do something amazing in the course of a week. And they can also be horribly depressed. But the depression also is very short-lived. So you're not going to make a diagnosis of a serious mood disorder in somebody who's horribly depressed for half a day. I mean, clearly they're reacting to something in their environment. When they're euphoric, they're reacting to something in their environment. It's not an intrinsic internal disease or biochemical disturbance. It's their reaction to something in their environment, and almost invariably, more than 90% of the time, they're reacting to a relationship issue, which doesn't just mean your partner or your boyfriend or your girlfriend. It could be your boss or your mother or your neighbor. It can be your dog. It's a relationship thing. We said this, these people often identify with feeling very empty, and as a result, they can be quite busy. They have rage problems. They have trouble controlling their anger. Most of their anger comes out in the setting of rejection or abandonment. It can come out and they're little things, like if I have a borderline girl on the ward and she comes up to me expecting me to be really nice to her and give her what she wants, and she comes up asking, I'm standing at the desk with 20 people talking to me, and she's asking me for a sleeping pill or something that I think we should have a more meaningful conversation about rather than at the desk with 20 people listening. And I tell her politely to go away, I'll see her tomorrow, and then she will have a rage. So it doesn't have to be a big relationship thing, right? It can be perceived a rejection from somebody who usually has some relative importance in your life. It doesn't have to be a traditional relationship setting. So we've said this earlier, people get transiently paranoid. We don't see it very often, but sometimes these people will be misdiagnosed as having some sort of paranoid disorder, because occasionally people with this diagnosis will be totally convinced that their bedroom is being monitored with little speakers and microphones and cameras, and usually it's transient, so often it's half a day or a day or two or three, but occasionally it's more. So if you get somebody coming in who really believes, usually under very stressful circumstances, that there are people out to get them and they're being monitored and people are plotting to hurt them, your first thought would be that this is some kind of psychotic disorder. But occasionally it happens in borderline people. And we see it also in dissociative disorders. So dissociative disorders are people that aren't solidly connected to reality. So probably the most common type of dissociative disorder is where people just sort of numb out a lot. So they'll have episodes of extreme, usually episodes where they're very stressful and they're thinking about stuff that's going on in their head, and they can drive from one side of the city to the other. And most of us can do that on a day when we're worried about something. But when I had a girl a decade ago who was going through a divorce and having a lot of trouble with her employer and was just stressed enormously. And she got into her car one day and she drove to Boston. And when she got to Boston, she had no idea who she got there. She had no idea what her name was. She didn't know who she was. So that's really extreme dissociation. And I've seen that 3 times in my life, I think, where people will travel long distances and assume a new identity or arrive after 3 days not knowing where they are. And that's a really extreme example of dissociation. With the borderline people, it's kind of more often than not in the state of rage or overwhelming emotional feeling where their brain is misfiring all over the place, don't remember for a while. But occasionally they will show up having come to and suddenly remembered who they are and where they are, and they can't remember where they've been for the last 3 hours. That's pretty disturbing to somebody. If all of a sudden you find yourself sitting in a chair in Rotary Park someday and you can't remember where they were for the last 4 hours, at my age you might think you had a stroke, but if you're younger you would probably go to the emergency and wonder what the heck is going on. So although we don't see it a whole lot, it happens. So those are the 9 possible criteria that people need to have to make this diagnosis. And you need to have 5 out of 9 to make the diagnosis. Most people have more. So hopefully that gives you a fairly good overview of what this is all about. So that's how we make the diagnosis. Those are the diagnostic criteria. So now I'm just going to tell you a little bit about some of the things that are fairly commonly associated with this diagnosis. Some of them we've already talked about. You can imagine that these emotionally unstable people are all, in this severe form of borderline personality disorder, have frequent crises. And, then they end up in emergency quite often. So these are pretty common people in our emergency room. We've talked about this before. When they look back, You know, every psychiatrist they ever saw is no good, every therapist is no good, their friends are all no good, and only the ones they have now are the best people in the world. And we see a lot of variability in diagnosis. So you'll see somebody who's 35 years old, who somebody thought, you know, usually people think at one point in their career that they were bipolar. So you could have a bipolar disorder. People that have borderline personality disorder in a fairly severe form don't feel like they're being very successful in their life. They're not doing well with boyfriends. They're popping in and out of the hospital. They're getting in trouble with drugs. They're not doing well with their family because their family doesn't know what to do with them. They're switching jobs. They're not doing well with jobs. They're not making any money. They feel like their life is not doing well. So often they come in and say, "Doctor, I'm really sad. I think I'm really depressed." But they're not often, they might be clinically depressed, but quite often they're just very unhappy with how their existence is going for all the reasons that we just finished talking about. So depression is pretty common. I think probably 30 to 40% of people with borderline disorder also have significant anxiety, so anxiety disorders are pretty common. So you get a lot of diagnostic variability. We'll talk about that a little more in a minute. They seem to be unable to solve some of the basic problems of life. They struggle with relationship issues, you know, the basics of hanging on to a job, the basics of deciding what kind of school are you going to go to, who are your friends going to be who are your friends going to be. And then these are the people, you know, we all know these people who seem to be doing really well at a job, and they look like they're about ready to get a promotion, and then they screw it up. Or they're in the best relationship that the family ever thinks they've ever had, and it just looks like it's going great, and then they screw it up. And sometimes they're going through some really meaningful therapy. They have a really good therapist. They're doing better and better and better, and then they don't come anymore, and they screw it up. So I think part of that is, you know, they know what's going to happen. You know, they fear that in this wonderful job that they have, that it's going to come to an end, and they can't deal with that loss, and they will have trouble finding themselves all over again. So part of it is preventing the disaster. So they screw things up before the perceived disaster happens. And you'll also see that much more commonly in relationships, where people who are borderline realize after a while that their relationships end in a bad way, and it's a horrible experience for them, because they become very upset with the sense of rejection, fears of abandonment, fears of being alone. So rather than they then have the option of just avoiding relationships altogether, or getting out of the relationship before the bad part happens. So they'll end a really good relationship, or end a really good job, or end a really good relationship with a therapist before the bad part happens. So you have to kind of know that, because sometimes when you ask them about all this stuff, they'll say, "Well, I don't really have abandonment issues. I never get there in a relationship, because either I don't have relationships with men, or I end them before I get into trouble." So you kind of have to watch for that part. What else can I tell you? These are the people that like having lots of animals. So these are people that have teddy bears. These are people that have lots of dogs and cats, because, you know, those, you know, animals are clearly non-threatening and have unconditional love that they return in your direction. They're very nice to have around, and they'll love you forever. So you see a lot of, and probably in big cities, most of these people have teddy bears, or they have dogs or small animals around here. It's amazing how many people have horses and big creatures that they can relate to unconditionally. We had this, I had a resident, family practice resident, I think, with me 6 months ago, and we were talking about these transitional objects and teddy bears, and I don't know how the topic got around to it, but somewhere in the course of our conversation, he asked me if you could measure the severity of a borderline personality disorder's illness by seeing how many teddy bears they had. So we were kind of joking about that. I don't know the answer to that. If you have 25 teddy bears, is your illness more worse than if you only have one? Is it worse? So then one day we got called, and he went upstairs to see this girl for me. And he came back and he said, "You need to come and see this girl. She's definitely the worst borderline I've ever seen." But he wouldn't tell me what he was talking about. So I went up to the surgical ward where this girl was, and I swear to God, she had a 6-foot pink teddy bear in the chair. So he thought, definitely this was the worst borderline girl he'd ever seen, because she had the biggest teddy bear. But she wasn't really. So we said that. Transitional objects. So they chaos in jobs, chaos in educational patterns, relationship problems. We'll talk a bit about this in a minute, but typically in their early lives, physical abuse, sexual abuse, neglect are common, and then that pattern will often repeat itself. So these are often, but not always, the people you see who will tell you that when I was a little girl, you know, my mother's boyfriends did bad things to me, my mother was an alcoholic and she had all these friends and they abused me sexually, or my mom and dad were never there, they both had to work so hard, and I had 12 brothers and sisters, so nobody had any time for me and I was neglected. So you see this pattern of sexual abuse, emotional abuse, and serious neglect occurring probably in 40% of borderline patients, but not always. It's important to sort of know that. And then, you know, not horribly surprisingly, when they're 17, they fall intensely in love with some guy, they get pregnant, they leave home or get kicked out of home, the relationship lasts for about 4 months, and then they're single mothers, and then the chaos begins. And then they end up in some bad relationships, and then by the time you see them in the 35, they've had a bunch of fellows that have been in their lives, half or more of them who've been abusive to them in one fashion or another, and then they're coming and looking for help. So in terms of what sort of psychiatric conditions often co-occur or exist at the same time with the borderline personality disorders, mood disorders are pretty common. Usually it's, as I said before, most common of these people are unsatisfied with their life, and so they present with kind of a chronic, mild depressive pattern. You know, they're kind of depressed, but they can have good days and bad. They're not horribly depressed all the time. They still function pretty well. They're at greater risk of having severe depression also, but depression is pretty common in varying degrees. It's usually a relatively long-standing pattern. Because of their chaotic lifestyle and their impulsiveness, substance abuse disorders are fairly common. When people are very impulsive, often they're looking for tranquilizing drugs. So I think most often these people would be tempted to get involved with sedative drugs. So they would smoke marijuana, they would drink alcohol, they might be interested in opiates, but they're pretty chaotic. So you see more than a fair share of people using stimulants like crack and crystal meth as well. So substance-related disorders are pretty common. Eating disorders, particularly bulimia, impulsive overeating, PTSD due to sexual trauma, ADHD, I don't know why, but it's also pretty common in these people. So over 90% of these people have 2 diagnoses, you know, and over 40% of these people have 3. So, and that's part of the problem, right? I mean, I think I spent 3 hours with some woman last weekend or the weekend before trying to figure out what was going on, and in the end she had borderline disorder, she also had bipolar II disorder, she also had a generalized anxiety disorder, she had obsessive compulsive disorder, and she had ADHD. And I didn't even figure all that out in 3 hours. I had to bring her back a few days later to do some more testing on her. So those are difficult people. How's your family doctor ever going to figure that out in 7 minutes, right? So, and even, you know, unless you really do this work and can find the time to spend that kind of time with people, they're at high risk for getting missed, these people, or they're at high risk for people perhaps seeing their borderline but missing the anxiety component or missing the substance abuse component or missing part of it. And you know, it's like anything else. If you have 5 problems, you know, we need to have a pretty comprehensive overview of what's going on with you for us to have a reasonable job of fixing it. We don't have to know every problem that you have the first time we meet you, but we have to be, you know, reviewing our diagnostic assumptions over time so that we eventually get the whole picture. Because if you don't get the whole picture, you're just going to mess up and you're going to fail your patients. So there's a lot of variability in this. I mean, these people are, you know, these are not cookie cooker people. They often look very different. But the most common pattern of that is this chronic instability occurring largely in early adulthood. And so then they have periods of mood or affective discontrol, impulsive discontrol, and they use a lot of health and mental health resources. So not all of them. There's lots of borderline people that don't show up ever in the mental health system, and they just kind of grow out of it. But the ones that have this in a pretty serious way, they use a lot of resources in the community and in the hospital, and you know, because they have a lot of problems. But we find that people that get involved with therapy and start to feel like they have some hope with their therapist or the psychiatrist start to get better in the first year. We find that as people get older, they become increasingly stable. So on average, when you pass 30 and have moved into your 30s, all the symptoms that we've talked about start to settle down. I can't think of a borderline woman I've seen over the age of 55 for a very long time. I know I've seen a couple of them, but sometimes it's interesting. You might see a woman who's 55 or 65 or 75, and you just can't figure out what's going on with her because her life has been chaotic, she's had terrible relationships. It looks like there has to be some explanation for why her life hasn't gone well, and yet all of the symptoms that we just talked about, and most of them are gone now. So often you're sitting with somebody who was borderline for 35 years of her life, and it all sort of slowed down, and now she's in your office and you're trying to figure out what the heck is going on with her, but most of the symptoms have settled. So that's pretty good news, I think, that for most of the wildly out of control borderline people, that things settle down pretty good for most of them. So studies have shown, if you look at people in an outpatient mental health setting, that after a decade, probably up to 50% of the people no longer even meet the criteria to make the diagnosis. So just a word on genetics. Borderline personality disorder is 5 times more common among the first-degree relatives of those that have this disorder than it is in the general population. So in the general population, the estimated incidence is about 3%. So if you have a borderline girl and look through her family tree, you'd expect that other people would have more like a 10 to 15% risk, 5 times more common. Also in the family history of borderline people, we find more substance use disorders. It's more common to see antisocial personality disorder, and we see more mood disorders more common in the family tree of these people that have borderline. So in making the differential diagnosis, just wondering if you see somebody in your office and you think this is probably what you're looking at, these are the ones that you have to be careful about, because if people have a mood disorder, often they'll have some affective or mood instability that might be reminiscent of the borderline. Sometimes people can be paranoid and psychotic for a little bit, which might make you think about psychotic disorders. Very impulsive people with a lot of moodiness tend to get into a lot of substances. So these can be confused fairly easily. People that dissociate a great deal, like the borderline girl that I told you that drove to Boston, it'd be she clearly had a dissociative fugue. She definitely meets the criteria for a true dissociative disorder, but underneath all that, this girl was classically borderline. So it would have been easy to say, well, oh wow, I just met somebody who had a borderline fugue and she has a serious dissociative disorder, and not look any further, but you need to look further, obviously. Sexual identity disorders, for the reasons that we talked about, sometimes can be confusing. A lot of these people have anxiety disorders. They're anxious people, they worry an awful lot. They can be obsessed with certain things, have phobias, be irritable, and the bulimia in particular is a common one. I have another lady she was kind of interesting. About 4 years ago when I was doing these series of lectures, I don't think I'd met her yet, and she came and she sat in the very front row and she listened to me do a bipolar talk. And then after the talk she came up to me and said, "Oh doctor, I have this bipolar, I need to come and see you." So we were thinking about trying to find some way to make her an appointment. And then I think the next week she came and I did a talk on anxiety disorders, and she said, "Oh, I don't think I have bipolar anymore. I think I have an anxiety disorder. I probably have panic disorder and something else and something else." And then the following week she came to see me, came to my little talk on ADHD, and then she thought she had that. So I think she came to 4 talks thinking that she had all 4 of those things. And in the end, I think she did have 3 out of 4. But it took quite a while for us to get that sorted out. So that was 4 years ago. And I think 3 years ago, I could honestly say this woman is now well. And we've looked after all of her conditions, but it took quite a while and took a lot of effort on her part and mine. So we said, I think, that mood disorders are probably the most common comorbid diagnosis, and also the ones that are often most easily confused with borderline, because there's a lot of symptomatic overlay. There's a lot of symptoms that the mood disorder people have that also occur in borderline personality disorder. Most commonly, persistent depressive disorder is the mood disorder that we see. So that's persistent depressive disorder is a DSM-5 term. So that's the term that comes out of our latest diagnostic book on depression. Just with the DSM-4 that probably most people are still using, we talk about dysthymia or chronic depression, so now they've lumped them into persistent depressive disorder. So really what we see in most people that have borderline people, probably more than 50% of them they would qualify for a mild or moderate mood disorder where they have some depressive symptoms that are quite long-standing but not severe enough to meet the diagnostic criteria for severe mood disorder. So they typically have a long-standing pattern of being fairly unhappy. So we have these things when you make a diagnosis of severe depression. Some of the signs and symptoms are called vegetative indicators. So if you have vegetative symptoms are usually the ones that are most closely connected with life. So if you don't eat, if you don't sleep, if you have no energy and your brain doesn't work, these things are typically seen in people that have true biological depressive diseases. And often if you see a borderline patient or a personality disordered patient who's talking about significant unhappiness over a period of time, they don't have these things. So typically in the emergency room, somebody will come in and say, I'm very depressed, doctor. So this would be a person perhaps with a borderline personality disorder. So they come in, they're very unhappy. But when you ask them, do you sleep and do you eat and can you concentrate and can you have any fun and do you have suicidal thinking? Usually they eat fairly normally. Usually they sleep fairly normally. Usually they don't have profound fatigue and they can concentrate pretty well on a good movie. So they don't have those kind of vegetative indicators, which is important to the clinician in the emergency room. And usually with a horribly depressed person, it's really difficult to get them to truly laugh and smile. If they go home and watch a good movie, they won't laugh and smile. And in the borderline patient who's got some depressive symptoms, usually their ability to truly be happy and smile in certain circumstances is preserved. So in terms of the confusion between bipolar disorder and borderline, there is a significant resemblance between borderline personality disorder and cyclothymia. So cyclothymia is kind of a mild type of bipolar disorder, and cyclothymia, the definition of cyclothymia is periods, people who have periods of mild hypomania and mild depression occurring frequently but aren't severe enough to meet the criteria for border or for bipolar. So in a cyclothymic person, they will have a half a day where their moods are euphoric and later on a half a day where their moods are seriously depressive, but not long enough to meet the criteria for cyclothymia. Or not long enough to meet the criteria for borderline or for bipolar. So it gets rather confusing. So where it gets confusing is, as we've said before, the borderline personality disorder patients have short-lived periods of abnormal moods, and the cyclothymic patients have short-lived periods of abnormal moods. So you need to kind of look at what differentiates the two, and probably the most important thing is in the borderline personality disorder, they don't meet all the criteria for hypomania, they don't meet all the criteria for mania, and the people that have cyclothymia don't meet all the criteria for borderline personality disorder. So if you just look at the mood thing, it can be a bit confusing, but if you run through the criteria that you need to meet in order to be borderline, these people do not. And if you look at the criteria that you need to meet in order to be cyclothymic, the borderline people don't meet those criteria either. So really it's just a matter of paying some attention to the detail and making sure your patient meets all the criteria and you don't get caught up in noticing that they have an abnormal mood and making your diagnosis simply on the mood, because you need to look at all the rest of the stuff. So if you have somebody who has a bipolar disorder or a mild variant of that, like cyclothymia, they not only are euphoric, but they also don't need much sleep. They talk too much, they talk too fast, they think too fast, they can't concentrate, they think too much about sex. And so they have all these criteria that they need to meet in order for us to say they're cyclothymic or have some form of bipolar disorder. If you're borderline, you don't. You have the intense mood, and the pattern is that this intense mood disturbance and other symptoms have been there since adolescence usually, because it's your personality. It has to have been there consistently, pervasively for years and years and years and years, and you wouldn't necessarily see that in the bipolar patient. So personality disorder diagnosis does require this ongoing, enduring pattern that can usually be traced back to adolescence. So where does this come from, this borderline stuff? So there are some biological or genetic issues here. There's a significant genetic contribution that is definitely not fully genetic by any means. But because we know that it's 5 times more common in first-degree relatives, you might think that that would suggest genetics. It doesn't necessarily. I mean, if you have a young person who's being raised in a family where there's lots of borderline instability, you know, maybe they're picking this up in a more of a learning thing, right, than genetics. But we know that there is a genetic component, and we also know that there's a non-genetic component. So from a genetic perspective, however, looking in the family trees of borderline people, we see more of these things than we would expect. So substance use, other cluster B disorders, particularly the antisocial personality disorder, conduct disorder in kids, learning disabilities and mood disorders. So those are the things that suggest a genetic factor. Some things that might suggest a neurochemical thing. A lot of these kids are found to have neuropsychological problems in kids. So if your borderline child ends up undergoing complicated neuropsychological testing when they're in grade 5, when we do neuropsych testing, we're measuring a lot of things. Is your brain good at all these different things? Like how fast can you do this? How is your memory? What is your processing speed? We measure tons of individual brain functions, and in the borderline people, a surprising number of them are not normal. So there are some neuropsychological difficulties that are a lot more common in the borderline group than in the non-borderline group. So, you know, it makes you wonder about brain chemistry, brain function. More commonly than what you'd expect in the normal population, people have impaired coordination, they have balance problems, sometimes problems with motor performance or gait abnormalities, and they often more commonly have learning disabilities, electroencephalographic or EEG abnormalities, and EEG abnormalities and ADHD. So all of these things suggest some kind of biological or physiological dysfunction in the part of your brain called the prefrontal cortex. And it's postulated that there seems to be some dysregulation of serotonin or dopamine, which seems to be supported also not only in our PET scans and fancy imaging things, but also if you treat these people with medications that would enhance their dopamine or their norepinephrine. In a surprising percentage of them, we see some improvement. So psychosocial contributions, I think where people really wonder about this is if you meet a whole bunch of people, if you meet a whole bunch of girls that have borderline disorder, if you read a book about stories about girls that have classical severe borderline disorder, it seems like you're just reading the same story and over again because you keep reading this girl was neglected in her childhood for whatever reason, this girl was sexually abused in her childhood for whatever reason. Later on, this girl might have been physically abused, then she got into some horrible chaotic relationships, then she began cutting, then she had chaotic relationships as an adult, she got into some substance abuse, and then ends up on a psychiatry ward. So you just kind of see that pattern that I just described over and over and over and over, and it of course makes you think that isn't that why these girls are like this? Because they were neglected, abused, and interfered with sexually, and then had, as a teenager, had chaotic, traumatic relationships and fell into the world of drugs, and isn't that why? So it makes you wonder what that's all about, but not everybody comes from that kind of a history, but it seems like we see it so often that you can't help but wonder about that. Because we see people have absolutely classical borderline personality disorders who come from wonderful, perfect, normal families as near as we can tell. And then we see, so about a third of people fit the classical idea that they come from these horrible families. About a third of people come from families where some of this stuff went wrong, and about a third of people come from families where we can't find any of this stuff. So it's a mixture. These are the adversities that we most commonly see that I've just alluded to. So let's talk a little bit about treatment opportunities and options for people with borderline character disorder. So I think we'll start perhaps by looking at issues around hospitalization. So as you can see on this slide, really probably the thing that we really need to talk about first is that this whole business of hospitalization is a very controversial topic with respect to the borderline patient. I think really that ends up being true because We see a lot of people in the emergency room that are coming in saying that they're going to kill themselves if we don't admit them, and yet the evidence shows that long-term stay in hospital serves no real purpose for these people. So being aware that keeping people in hospital for a long period of time or an average length of stay is often counterproductive makes it pretty difficult to keep that in mind when you're assessing somebody in the emergency room who is insisting that if you don't admit them that they'll kill themselves. So not surprisingly, we end up with physicians and crisis staff deciding that they are going to admit somebody who claims to be suicidal, even though they might be dubious about their actual intent. And often that gets done, I think, hopefully in part because we think that perhaps it'll be helpful to the patient, but also in part I think people worry about legal repercussions of making a mistake. So certainly if you have some young person in your emergency room that is saying that they're going to kill themselves, and even if you feel that probably they're not honestly likely going to end up being successful in the next few days, it's still something that we probably as good clinicians have to take some pretty serious thinking and a little bit of time to make decisions about that. So part of what goes on there is, as I've said, there's no evidence really to indicate that long-term hospitalization or even average length hospitalization proves to be effective in any meaningful way for these people. There is evidence to show that short-term hospitalization can be effective, but long-term or just even average length of stay is generally felt to be ineffective and often ends up in these people regressing or going backwards rather than going forwards. If you take somebody in the hospital and stick them in there, I mean, if you think about it, the hospital is a very nice place and people cook for you, people are friendly to you, you make new friends there in a hurry. You don't have to continue managing your life. And I think really the theory behind the problem with hospitalization is in therapy for borderline patients, we're encouraging them to become more responsible and live their life in a healthy fashion and to empower them, I guess, to carry on the outside. And if we admit them and start doing everything for them, you can see that quite likely they'll go backwards and regress. So if you do admit them, you need to admit them into a very structured environment, have very clear expectations for them, and try and keep their stay short. So there are exceptions to these comments that I've just made, and we'll talk about those in a minute. However, as I've said, short admissions, making people stick to the routines as a condition of admission will make these things more reasonable. Okay. So as I've said, there are exceptions to the rule where sometimes we think that a longer term admission might be useful for a borderline patient. So we're still saying that short-term hospitalization or perhaps outpatient treatment is probably the most appropriate for the usual borderline patient, but there are exceptions. So some of the more common exceptions, but even these again are controversial, and not all experts in this area would agree with this, but some of the exceptions where we would say that the borderline patient should be hospitalized for a reasonable length of stay would include the following. So if they've been in brief hospitalization and if they've been in outpatient treatment and they've been doing those things for a reasonable length of time and things are not getting better, then sticking them into an inpatient ward to take a closer look and perhaps do something more in depth can be reasonable. If the borderline patient is depressed or perhaps bipolar or psychotic and they have a Axis 1 condition going on as well as their borderline, then we might really admit them to try and disentangle what's going on and to try and treat the Axis 1 condition without really trying to pretend that we're going to do much good for their borderline condition. These people, as you know by now, tend to be quite self-destructive. They cut, they burn, they hurt themselves. Some of them have very significant tempers. If these things are really getting out of control in the community, good reasons to consider admission. If they become psychotic, and you'll remember that these people most commonly have brief psychotic episodes, but if their psychosis is more than what you'd usually expect or is more concerning than what you might normally see, we might consider admitting them. If we're not too sure what's really going on, we want to clarify things, we might do that. If we see somebody who is living in a very chaotic environment that doesn't provide any support, we might do that. Helping them with substance withdrawal might be a reasonable thing to consider hospitalization for. And as you'll know, the borderline people have huge difficulty with losses and rejection issues. So if you find a borderline patient that legitimately is struggling with some enormous losses, and you feel that they simply aren't going to be able to cope with those losses on the outside, then admitting them is pretty sensible. So I saw a young guy not too very long ago who was 18 years old, had been in and out of the adolescent ward with borderline personality disorder for a couple of years, and now that he was 18, he became my patient. So this guy had been living at home with his mother and his stepdad. Excuse me. And his stepdad became quite disenchanted with this guy and kicked him out. So he kicked this guy out of the house. Mother sort of withdrew her love from this fellow for a while. He started using drugs and he was homeless. So when I saw him in emergency, he had probably 25 cigarette or cigar burns on his forearm. He'd done a really quite serious overdose. He didn't have any structure in his life. He felt threatened over the loss of his mother's love, and he was using drugs. So, I think a situation like that sort of highlights a number of things there, that he had a lot of burns going on in his arms. His environment didn't any longer provide any social support. He was homeless. He had a history in his family of a lot of his relatives were bipolar. The child psychiatrist who looked after him wasn't sure whether he was bipolar or borderline, so it was really unclear what was going on with this guy. He was using substances and was heading for withdrawal. And he'd had some really big losses. So he was a fellow that I admitted, and hopefully his stay, if I remember right, was less than a week, so it worked out pretty well. So that's a pretty good example of the kind of situation that's reasonable to admit these people for. So there is a fellow at McGill University in Montreal called Dr. Joel Paris, who's really spent his life working with the borderline patients and studying them. He's probably close to my age, I would say, or a few years older than me, perhaps. He's written some really good books and done a lot of research. So in 2002, we reviewed 170 papers on borderline, with particular emphasis on the topics of suicide or suicidality. And pulling out some important facts from those articles, he says that he sees about a 10% rate of completed suicide by reviewing all these papers. He points out that only a minority of the suicidal threats and behaviors occurred in patients that are in active treatment. So most patients, according to his review, that actually seriously attempt suicide or successfully attempt suicide are no longer in active care. So there seems to be a lot of support for that. If your patient's hooked up with the proper therapeutic group or the proper therapist, that their risk of suicide is diminished. And more often than not, it's the patient that's moved on to be perhaps 35 and treatment has kind of come to an end and winding down, and they feel that treatment hasn't really helped them. These are often the group that are at greater risk for successful suicide completion. So older people often, relatively speaking. And then, of course, suicide is also more common if there's more than one illness going on or if there's substance use disorders going on. So when you think about borderline, I think some of the things that are important to remember, the borderline patient usually presents saying that they have mood swings. So usually when I meet them, they're coming in complaining of mood swings, or they're complaining of stuff related to their suicidality, which is chronic. And trying to differentiate the mood symptoms of the borderline patient from somebody who's depressed or somebody who's bipolar is sometimes pretty difficult. But if you can be persuaded that your borderline patient that seems to be profoundly sad for 2 or 3 days in a row, if you can be persuaded that that's a borderline phenomenon and not a mood disorder phenomenon, it's important to understand that the treatment, not surprisingly, will be different. So if you have a borderline girl coming in, I had a borderline girl in the hospital last year who child welfare took away her baby after she'd had her baby for 3 months, and following that she became devastated and was in, every day she was crying and she had all sorts of signs and symptoms of depression, but her depression was related to her loss, and you could see some reactivity in her mood in the evening in the hospital, and putting her on an antidepressant would have been just a waste of time. And it's similar to people who perhaps are going through serious grief reaction, where you understand why they become so sad and why they're sad all the time, and they probably look like they meet all the criteria for depression, but treating them with an antidepressant won't work. So it's important to understand that the mood symptoms are mechanistically different. They arrive through different mechanisms, and not surprisingly, different approaches to helping with these things are required. And more specifically, an antidepressant won't help the depressive symptoms of the borderline patient. So another thing to recall is when we often think about self-injury when we talk about borderline patients. I think it's because the thing that comes to mind often is in our memories of dealing with borderlines is some of the self-mutilation, burning, biting, cutting, and things like that we see. So it's probably important to realize that there are a variety of behaviors that are included in this term of mutilation, including burning, biting, sunburn, hair pulling, hitting, med abuse, substance abuse, promiscuity, accident proneness, and that only names most of them. So lots of different things people do. 75% of people that are habitual self-mutilators change their methods over time. So with respect to medication, I think the most important thing I can tell you about medication is there is no medication that is geared to the treatment of borderline personality disorder. There is no one drug that is expected to have any significant impact on the borderline personality disorder patient. So psychotherapy clearly is a treatment of choice in these cases, but we do have some medications that are helpful. But I think when you start prescribing these medications to your patients that are borderline, the first thing you really need to do is to make it really clear to them that you're probably not talking about magic. You're probably talking about a 10, 20, 30% improvement in some of their symptoms. And if, for example, you use a type of antidepressant in these patients, it reduces their impulsiveness, and I think as a result of that, it reduces the frequency of self-harm. You need to explain that to your patients and say, we're going to give you these drugs. I'm hoping you'll be less impulsive. I'm hoping that when you get really upset and you feel impulsively that perhaps you should hurt yourself or that you should do something wild and crazy, that you'll have 3 or 4 seconds more to think about it. So I really do find that patients, I quite often put borderline people on SSRIs, so I'll put them on some Zoloft or Prozac or something. And I really do find that probably 50% of them come back to me and tell me that that they notice that when something is going wrong in their life, and normally they would be feeling overwhelmed and lose control and perhaps cut themselves or go get drunk or do whatever, that they have more time to think about it and they make better choices. So quite a number of people, I think, find these drugs to be really quite helpful, not to alleviate their depressive symptoms, but yes, to improve their impulsiveness. We do use mood stabilizers. I sort of use them as a second line thing. I use the antidepressants first. Mood stabilizers do seem to have some benefit for behavioral discontrol and reducing the impulsiveness. And sometimes these things get used together at the same time in the same patient. We see a lot of patients that come seeking benzodiazepines. I think we talked a little earlier about these people are anxious, they lead stressful lifestyles, they're often getting themselves into a stressful situation. So for them to come and ask for things like benzodiazepines or tranquilizers, anxiolytics to try and relax them isn't too surprising. Knowing as we do now about their significant risk for addiction, we're pretty cautious about passing these things out. And basically, most experts would say that benzodiazepine should not be used in people with borderline personality disorder because they become disinhibited. It's like having a couple of good drinks. If you're kind of an impulsive person and you have a few drinks, or if you have some benzodiazepines, you might be more likely to get disinhibited and get into trouble. So we also use antipsychotics occasionally if your patient comes in and is psychotic. Short-term antipsychotic use might be helpful. And some of the newer antipsychotics seem to have some impact on the serotonin levels in our brain and therefore provide some ability to modify people's moods. So the ones I think that are useful and worth considering in these people are the novel antipsychotics, some of the antidepressants, and some of the mood stabilizers. For me, I find, the antidepressants are probably most likely to be effective, mood stabilizers second, and antipsychotics kind of questionable. But like everything else, if you try 1 or 2 things and nothing works and your patient is really having a hard time after a discussion with your patient about the pros and cons of various medications, you might elect to try antipsychotics, or you might elect to try a couple of these things at the same time. So, but as I said in the beginning of this slide, the important thing for people to realize is there's no magic pill for this illness. So, as I've also just finished saying, group therapy is the treatment of choice. Traditionally, we've used all sorts of different types of groups for these patients, non-structured groups that teach cognitive behavioral therapy, and now dialectical behavior therapy groups have become very common. So in Red Deer, dialectical behavior therapy isn't available. It's sort of the recognized treatment of choice for the borderline patient these days. But we can access it in Edmonton and Calgary. Dialectical behavior therapy was a therapy that evolved out of cognitive behavioral therapy. It was developed by a lady called Marsha Linehan, who's from Seattle, and it came out of CBT, as I said. So it's an interesting kind of therapy. It's very specialized. I can't begin to tell you all about it tonight. It can be done individually. It can be done at home in a workbook, and I find that quite useful for some of our patients in Red Deer. And it can be done in a group. So some of the basic underlying thinking behind DBT is that the philosophy of DBT includes these notions that patients are already doing the best that they can do. If they're not doing very well, it's not because they're not trying. DBT believes that patients are willing to get better. It believes that people need to try harder and to be more motivated, that people have not caused their own problems, but regardless of that, they have to solve them anyway. And they believe that the lives of the suicidal borderline patients are essentially unbearable. They must learn how to do things differently, and that there's no failing in therapy. If you put your effort into it, there's no failing. And the therapists treating borderline patients need support also. So in a traditional dialectical behavior therapy group, you'd find that once a week the group therapists are meeting and debriefing themselves and doing therapy among themselves and getting help among themselves. So it's a very interesting process. It's not available in Red Deer. I use programming mostly through the Edmonton hospitals, but it's available in Calgary. I think in 2 out of 3 of their big hospitals, and it's available in Edmonton in all 3 of their hospitals. So I find the program that probably works best for most of my patients is one that works out of the Royal Alec. And they have a similar one at the Grey Nuns where people can go to Edmonton. They go up to Edmonton 1 day a week. They meet with their therapist for usually 90 minutes, and then they go to a 2-hour group. So they might go up on a Wednesday afternoon, arrive in Edmonton at 2 o'clock, and they're home by 8 o'clock at night. So it's pretty doable for most people. And I find, I think some people, sometimes, I guess it's like everything else. I think there are some people that do just amazingly well with DBT. A lot of it has to do with ability to grasp psychological concepts, your level of motivation, and I think also to some degree your intelligence, because some of the constructs and things that they teach in these groups are pretty advanced. But I've seen some remarkable improvements in people going through these groups, and certainly these days I think it's by far the best that we have to offer. And certainly when I send people up to Edmonton for DBT, they're seen by psychiatrists for a while up there. Often the psychiatrists actually run the groups, and they're maintained on the medications, and usually if they think that what I've been prescribing isn't quite right, they might adjust them, but generally the DBT therapists are quite strongly in agreement of using medication along with their group therapy. So I think that kind of sums up treatment opportunities for people with borderline. Hospital is an option. Short-term hospitalization is a really good option. Day programming with groups is important. Some medications can be useful. Dialectical behavior therapy is kind of the cornerstone of recommended therapy currently. And I think I'm all done, so if there's any questions, things like that, I'm happy to take them. They run groups for people of all ages. So what you want to do is you want to phone, what I do is I phone the Department of Psychiatry at the Royal Alec Hospital, tell them that I have a patient who's interested in attending outpatient group therapy. And then they send me a referral form in which I can tick off, they send me a referral form that lists the number of outpatient therapies they do for what sort of conditions, and I just tick off dialectical behavior therapy, and then they ask me to put in a diagnosis, and I put in borderline personality disorder, and then they sometimes will do a telephone interview with the person, or sometimes invite them up to Edmonton for a formal interview. Usually the wait list is, I think, maybe 3 months, but they would interview you before that, and if they felt it was more urgent, they would do it before that. So you can get this done. You can access these sorts of services at the Royal Alec, at the Grey Nuns, at the university, and in Calgary you can access it at the Rocky View and at the Foothills. So they're available in most of the big hospitals in Alberta. I just use the Royal Alec because it's worked for me pretty well. I think you can self-refer. They might want an accompanying letter from a family doctor. I'm not sure about that, because I often tell my patients, go online, get them to send you the application form, and bring it to me. So I think you could probably get an interview without a physician's report, perhaps. I'm not sure about that. But you can certainly get the application form yourself, and then if you want to, if you need to, you can take that to your family doctor, or you take it to your mental health worker. I think they would accept that also. So. The other thing I was going to mention, I guess, just so that I don't lose it altogether, was so the mainstay of treatment is certainly recognized as being psychotherapy. I think for years, for various reasons, people have tried to help people with this condition with medications. And now, existing in a world of researched, evidence-based medicine, we can sort of tell you that we have evidence to say some of these drugs work and some of them don't. There's no drug out there that will cure somebody with a borderline personality disorder. We have drugs, for example, selective serotonin reuptake inhibitors or antidepressant drugs that work by increasing the levels of serotonin in your brain. They're very effective at reducing people's impulsiveness. So I would use them in a demented patient who's becoming very impulsive. I would use them in somebody who perhaps has all sorts of psychiatric problems where you want to reduce impulsiveness. And we use them in borderline personality disorders to reduce their impulsiveness. So there's not a lot of research out there yet, but enough to say that there is good research in fairly small groups of people to show you that we can reduce the impulsiveness. Probably, in my experience, I would say that 50% of people with this disorder that have significant problems with impulsiveness will find that if they're on one of these medications, a SSRI, that their impulsiveness will be reduced significantly. So what you see then is somebody coming in saying, when I feel like I'm getting upset and I feel like hurting myself, or when I feel like I'm going to lose it and start raging on somebody, or when I feel like I'm just going to go out and do something wild, I have 5 more seconds to think about it, and then I can make a better choice. So for some people, it makes a really big difference. For some people, it makes a moderate difference. For some people, it makes no difference. But those are the drugs that, in my opinion, are of the most use, but I'm not trying to portray them as any kind of cure. And then there's also research to show that some of the mood stabilizers, will sort of reduce some of the mood swings. And I've had some luck using those things. I think it's, you have to be careful as a prescriber that your patient understands why you're treating them with an antidepressant or why you're treating them with a mood stabilizer. Because if you treat them with an antidepressant and they're expecting suddenly they'll feel immensely happier, they're not going to get that. They need to know that you're doing this to reduce their impulsiveness, which hopefully will result in more happiness, but it's this kind of a secondary effect. And if you're going to treat them with a mood stabilizer, you're not going to eliminate their mood swings, but you're hoping to reduce them. So, if you get really lucky, I find that if you put people on a good antidepressant of the SSRI type, which would include Prozac, Luvox, Celexa, Cipralex, Paxil, and I think that's it. One of those drugs, that will enhance your serotonin. If that reduces their impulsiveness, then sometimes that might improve. People will say, well, that makes me feel better by 30%. Maybe if you're lucky and a mood stabilizer helps a little bit also, then you might get people feeling better by 40 or 50%. So if you're lucky and you can pull that off with medications, then the type of work that you have to do in therapy is less, and I think you'll do better in therapy if the medications will help. So without any doubt, if you look on the internet, you'll find that the treatment of choice for this disorder is psychotherapy. But you'll also find, if you look hard enough, that there's good research to support cautious, careful use of certain families of drugs at this point that are non-addicting drugs. Risperidone is also used to reduce impulsiveness. So there's not a lot of research to show that works, but we use risperidone in ADHD kids and ADHD adults so we use it in a lot of conditions where impulsivity is a factor, and it seems to be pretty effective, but I haven't seen any research to support its use in the borderline personality disorder, but it's kind of a common sense application because it does reduce impulsiveness in a lot of other conditions, and risperidone will also make your antidepressant work better. So if you're on an antidepressant being used to help your mood or to reduce your impulsiveness, and you add risperidone to it, it'll make your antidepressant work better at reducing the impulsiveness or helping your mood, right? So I think there's a good role for that drug as well, and for other related drugs. I just don't want to sound like this is a condition where drugs are magic. Sometimes, but sometimes the response, I have had quite a number of patients who feel so much better on the medication that it just then allows them to carry on with their life while they're getting their therapy. Sometimes they're very useful and sometimes they're not of any use. And it's really easy as a prescriber to get caught up in wanting to help these people with medications, because a lot of us we write a lot of prescriptions. Family doctors don't have time to do the kind of counseling and stuff, so they're quick to get out the prescription pad sometimes when people are talking about mood swings. And you have to be pretty careful, because you don't want your patient ending up, if you try them on an antidepressant and that doesn't work, and then you put them on some risperidone and that doesn't work, and then you try something else, and before long you have them on 5 different prescriptions and not feeling any better. You don't want to get into that, right? So you need to be careful with this stuff. If you're going to try a drug and it doesn't work, get rid of it before you try another drug, Yeah, in terms of, do borderline girls have much worse problems premenstrually, for example, or during pregnancy or postpartum? Absolutely, yes. But there is no evidence that I'm aware of that would show that treating people with hormones will help, right? And that's, there's evidence that mostly comes out of the UK suggesting that, the use of hormones for the treatment of things like postpartum depression or severe PMS is useful, but it's kind of contradictory evidence. So, but absolutely, girls that are moody and have this stuff will usually have much more difficult time in the 2 to 7 days before their period, or often more trouble in the postpartum period, and often more trouble in the pregnancy period, because those are periods when your hormones are out of whack. So it's a good point, and you're right. Not that we know of, but you're talking to a guy who's not an expert in that stuff, right? So I think it's, the problem with trying to answer a question like that is, in the world of medicine these days, they expect doctors to not prescribe things unless there's evidence to support the fact that they work well, right? So if you want to bring risperidone or Prozac or an antidepressant into Canada, you have to do all sorts of research to prove to Health Canada that your drug works to some degree. If you want to bring supplements into Canada, you don't have to do any research. So there's no research to prove that they work. So doctors and pharmacists we're being told, don't be supportive of things that don't have research, because now we're moving into a world of evidence-based medicine. Clearly there are things that you can get from a health food store that help people with different things, but you're not going to get a really good answer out of a doctor or a pharmacist, because it just isn't what we do. But there are things in the health food store that work. There are things from the health food store that I encourage people to take. I just don't, we're not taught a whole lot about that stuff. We're taught to avoid things that aren't supported by research. So I'm not saying they don't work. I'm just saying you're asking the wrong guy. So.